Thanks, Dr. Chapman and Dr. Ascuyi and Dr. Mendel. It's always a real honor to be here. I've told some of the resident folks in the past I used to record all of these lectures. I have a whole playlist on YouTube of the Seattle Science tumor course that I've learned a lot from over the last 8 or 10 years. So it's always a real honor to be back here as part of the faculty. So this is a pretty tough topic to go over. None of us can really predict the future, but we do have some great models and tools in our bag that we can help us to make the right decision for patients. So all of us have seen this slide before, the NOMS framework, right? All of these in their own right essentially contribute to survivorship: neurology, oncology, stability, systemic disease. We really have to acknowledge, though, that we're dealing with stage 4 disease in a lot of these patients. So all these patients, to some degree, do have a limited life expectancy. So really, why do we care about accurate survivorship prediction? As spine practitioners, really what it boils down to, the core of it is we really want to stratify treatment options from aggressive to palliation in patients. What we care about the most is seeing that our patients have been provided some degree of meaningful recovery after our intervention, right? What I care about is when I go to clinic and I see my post-op patients, that they're happy, that they're doing better neurologically, that they're satisfied that they had an intervention with me. If we have happy patients, we have happy surgeons, right? What we really don't want to have, though, is patients recovering from an operation for the remainder of their lives. And I think many of us can attest to this, that there's a fairly high mortality and morbidity rate with the surgeries that we do. And these are complex cases, right? These patients come in, they have severe back pain, lytic deformities. Sometimes they have non-contiguous, but multiple levels of ventral epidural disease. These are fairly big invasive operations. And you have to understand that when you get yourself intertwined with one of these cases, there's ultimately a price to pay, right? This is a patient with renal cell carcinoma. He's got sagittal plane deformity in his neck. He has a perched facet in the back. His neck is all pitched forward, right? And technically, it looks like a sound operation, but a few weeks later, they come back with a small hole, and then the hole's a little bit bigger, and then you're staring at hardware, right? You can run into other complications. This is a patient that had a pathologic fracture. Just because they have a pathologic fracture doesn't mean that they have good bone health at the other levels. They harbor other diseases as well, like osteopenia and osteoporosis. And although this patient with multiple myeloma didn't have other sites of disease in this snapshot, the patient had severe osteoporosis. So when we go and we do this posterior corpectomy, we expose out the nerve roots, we put our expandable cage in. A few weeks later, the patient comes back to clinic with worsening back pain. They've got some new radiculopathy, and we can see that the cage has kicked out. Right? There's other situations where we may operate on the patient, and we could very quickly turn what looks like a spinal oncology operation very quickly into a spinal deformity surgery. On occasion, we'll have patients that develop adjacent level oncologic disease, or maybe due to our poor techniques of dissecting to the UIV+1 rostral levels and buggering up the facets and the interspinous ligaments, such as what happened in this case. Like I said, you could very quickly turn an oncology case into a deformity operation. And now we're having to employ techniques such as tethering to try to prevent PJK from happening again. The other big reason that we care a lot about accurate survivorship prediction is because, as much as we may or may not want to admit it, we do live in a cost-conscious healthcare environment. There's a lot of pressure externally and from our hospital systems about using cost-effective techniques. Now, a lot of the tools I'm showing at the bottom, these implants, are very effective, but they can be very financially costly as well. And we're really pushed to appropriately allocate resources to patients that have the longest predicted survival. So how do we predict survival in the metastatic disease patient population? There's a lot of prerequisites. We have to know what their cancer type is, their histology, their sensitivity to specific interventions like chemo, radiation, their nutritional status, their coagulation status, what their immune response is like, their current functional status, like their KPS score, neurology, and obviously spinal stability. And if you do a deep dive into the literature, you'll see that there's about 150 results on the different types of prognostic scales that are available. The problem with these prognostic scales is that they themselves do have a finite lifespan, right? Because at some point they stop representing the current trends in cancer care. And if you look at some of the most common ones, I think most of us in this room are familiar with Tomita, the Tokoyashi, the Lay scores, the Bauer scores. There's problems with all of these, right? These scores are generated from retrospective data. There's selection bias in these So the scale that I most commonly use in my practice now, and I'm trying to teach to our residents at UNC, is the New England Spine Metastatic Scale score. It's a very easy score to generate. It looks at 6 month, 1 year, and overall mortality. You could have very poor survivorship with a score of 0, or fairly reasonable survivorship with a score of 3, as you can see here. And really, the four main tenets that it looks at is the primary tumor behavior, the systemic disease cancer burden, the ambulatory status, which is really a proxy for pretreatment function, and then also their albumin levels as well. And this particular study had been prospectively validated at 3 different academic centers in the past. So if there's any 3 items to take away from this, it's higher performance status, better neurological function, and the absence of visceral metastatic disease. These all predict fairly reasonable survivorship at 1 year. You do have to be very careful, though, when you ask patients about their ambulatory status. And I could show you a quick example as to how you can get in trouble with this when you're trying to generate a score with this particular scale. This was a guy I took care of a few months or so ago. He's an 81-year-old guy. He's got a history of relatively well-controlled prostate cancer, and he came into us essentially non-ambulatory. My residents called me in the middle of the night and said, this guy hasn't really walked in 2 days. What's his motor exam like? He's about 1 out of 5 in his lower extremities. But the key question is, what were you like 2 months ago? What were you like 2 days ago? And when you take a deep dive and you really stand at the bedside and ask the patient and their loved ones essentially what their neurologic status had been like, it seems like he was a pretty functional guy, right? So 2 weeks prior, he was jogging 3 miles a day. So we still took him to surgery. And my point here is that being non-ambulatory for 2 days is a lot different than being non-ambulatory for 2 months, right? So you really have to get into the granular detail as to the patient history in these situations. And this guy has gone on. He went to rehab. He's getting radiation. He did very well. He actually can ambulate now, albeit with an assistive device. But if you take it at face value and say, "Oh, this guy hasn't ambulated for 2 days," you may X this guy off and say maybe he's not a good surgical candidate. But we gave this guy a chance, and I'm glad that we did. You have to be very careful too about some of these older slides. Some of my old mentors would put some of these slides up in their talks. Lung cancer, they live for 4 months. Breast cancer, 24 months. This is obsolete now, right? Because now we're looking at things like personalized therapies, checkpoint inhibitors, immunomodulators. My good friend that works right down the road from us at Duke University, Rory Goodwin, he's doing some spectacular work with molecular markers. And he really uses this to his advantage to help make surgical decisions in patients, right? If a patient has a tumor that has a mutation that's amenable to targeted therapy, he's found that these patients have longer survival overall. Okay, they're more suitable surgical candidates as well. And the other benefit of understanding their molecular markers and mutations is that we understand that there's options in their postoperative period to control their systemic therapy. Some of these targeted inhibitors also can cause the tumor to completely regress. So a patient like this is the patient who came in with severe myelopathic symptoms from the thoracic spine. We actually never operated on this patient. They were put on a targeted therapeutic, and we could see the post-intervention scan on the far right. And this patient went on to do very well. So some of these targeted therapeutics really mitigate the need for any type of surgical intervention. I can tell you from experience that if you're planning on doing a surgery like this is a patient who had renal cell carcinoma, and you're planning on doing a corpectomy and putting your screws and rods above and below, you better understand where they are in the spectrum of cancer therapy, right? So a newly diagnosed cancer that's treatment naive, these patients are likely to benefit from surgery, right? If the patient's on their 4th or 5th line of therapy, they're probably not going to benefit a whole lot from an operation like that. So you can take the same exact patient radiographically, clinically, with the presentation of thoracic myelopathy, maybe they're losing function in their legs. If they're on their 4th or 5th line of therapy, that's probably a patient that maybe we shouldn't take for a surgery that invasively. Okay. You also need to think about when a patient's on targeted therapeutics, issues that are related specifically to these medications, like wound healing compromise, Avastin, targeted therapeutics like RTK inhibitors. Maybe you have to get your plastic surgery colleagues involved prior to the operation. This is a recent case that we did at UNC. This was a case of a lady, middle-aged woman with unfortunately diagnosed with non-small cell cancer. We can see clearly here she has a cerebellar met. One of our cranial oncology partners took it out. She had radiation, was put on targeted therapeutic. And a few months later, she came back to the emergency department, and the residents called and said, Dr. G, it looks like she's got a wound infection. We understand this was a posterior fossa incision, but it looks like that she has a wound infection of her upper cervical spine. We took an MRI scan, and it actually looks like that she had seeded her tract, right? So this is a patient that we definitely need our plastic surgery colleagues involved for. So, as surgeons, we could certainly take all of this out and get a good oncologic result, but I can't close this up myself. I need help. I need our plastic surgery colleagues to help us to turn a flap and get this healed out properly. Some of these other targeted therapeutics on the market, they can cause significant bleeding. If a patient is on one of them, maybe we want to consider delaying surgery to allow for a specific washout period. And the same thing goes for myelosuppression as well. So I think Dr. Gibbs is planning on talking about sarcopenia and frailty a little bit later, but I do want to quickly touch upon that it is important to consider sarcopenia in these patients. Sarcopenia essentially is the loss of muscle function, loss of muscle fibers. Sarcopenia has been shown to be an accurate predictor of survivability. There's several good studies that are out there in the literature right now showing that the psoas muscle size is really a good surrogate to show us what level of sarcopenia the patient essentially is harboring. And it really predicts 90-day and overall mortality, independent of demographics, functional, oncologic, and surgical characteristics. So you may be wondering, how do we quantify sarcopenia? There's a very quick, easy way. I think anyone that has access to a PAC system, if you right click on it, just like this, you can go down to your annotations, your ROI ellipse. And I know some of us, when we do deformity surgery, we do like to measure the Hounsfield units, and you can also measure the volume of the psoas muscle as well. This generates a score here. And then we can reference our literature, and we can see that these patients, based on this particular studies, are put into different tertiles. The larger your psoas muscle volume, the greater your survivability index. You do have to keep in mind that people of very short stature are likely to have a smaller psoas muscle. So this is why we actually look at the psoas muscle to vertebral body ratio to give us a better indication as to how sarcopenia is playing a role. There are situations that we may want to actually take a more granular approach to measuring sarcopenia. I think as surgeons, a lot of us kind of obsess over numbers. We talk about SIN scores. Those of us that do deformity, we talk about C2 slope, T1 slope, C2 to 7 SVA, PI-LL mismatch. A lot of us really kind of get intertwined with all the numbers, right? But if you look into the patients more holistically, there's really a lot to unpack with them, right? It's not just about their alignment or what their SIN score is. There's a lot to unpack as far as their whole body composition, right? And there's been some great work done out of MSK and MGH, Dr. Bilski, Dr. Shin, showing that there's decreased survivability index in patients who have lower skeletal muscle mass, decreased skeletal muscle quality, decreased visceral and subcutaneous adiposity as well. And essentially what this tells us is that this is essentially a quantification of cachexia. There's been some great work out of MSK with Dr. Bilski as far as looking at artificial intelligence. I think we had touched upon this briefly last year as well. OncoCast, this is an AI algorithmic process. It's a machine learning prognostic tool that looks at clinical characteristics, pathologic features, and molecular profiling. I'm a bit biased, but I really think that the best way of predicting survivorship in the metastatic disease population is really your own experience. This was a case that I did my first year in practice, which was about 5 years ago. This was a gentleman in his mid-60s who came in with 3 out of 5 strength in his lower extremities. We could see here that there's this is an L2 pathologic fracture. There's some retropulsion into the canal, pretty severe epidural disease circumferentially around the cauda equina. They have a history of urothelial carcinoma. They have a SIN score of 13, as we could see here. So I look at this scan, I examine the patient, say, this is something, I could take on. Zia taught me this the year before. I could put 2 screws in above and below, maybe squirt some cement in, take out the vertebrae, expose the nerve roots past the DRGs, and pop a cage in. And I can tell you one thing I was not thinking about at that time was predicting this patient's survivorship. I certainly wasn't thinking about molecular markers or how to measure the psoas volume relative to the vertebral body volume. And this is the type of a surgery that we did, where we take the patient 2 up, 2 down. It's a fun operation. I enjoy doing these. You see some beautiful anatomy. We take out the pathologic fracture. with the cancer. We can turn our cage 90 degrees, and we could get a really nice clinical and radiographic result in the short term. The problem with this is that this was probably the wrong patient to take for this operation. Dr. Mendel talks about wrong patient all the time, right? Wrong surgeon. I was capable of doing this operation, but this was the wrong patient. This was a 6-hour surgery, 7-hour anesthetic event, lost almost a liter of blood, and the patient came back about 2 months later with sepsis and eventually passed, unfortunately. So my point here is that you really have to understand the patient population that you're taking for these surgeries. If you look back retrospectively, this patient had a New England Spine and Metastatic scale score of 0, right? They had brain mets, their entire spinal column was peppered with metastatic disease. They essentially had a 6-month mortality of 85%. And because I wasn't thinking of that, we took this wrong patient to surgery, right? So this is really where experience plays a really significant role. Maybe in the future, this patient's a better candidate for LIT or for RF ablation, maybe a minimally invasive approach to decompress the spinal canal and then perform percutaneous vertebroplasty. So I think now that, the paradigm has really shifted more towards MIS approaches. There was a great talk just a few moments ago on radiolucent hardware rather than taking the whole vertebrae out now in a lot of these cases. We'll still take the pedicles down. It's still a moderately invasive operation, but rather than flaying everything open and taking the whole vertebral body out, which could add, an hour or 2 hours to the case with a lot of risk and blood loss, now we just take the pedicle down, pop the facets out, we get into the ventral epidural space, and then we take out that ventral epidural component of the disease, and then we send them for SBRT later on. We have to learn how to properly scale our operations as time goes on, as we gain more experience. What can we get away with? Maybe rather than doing 2 up, 2 down with a cage, maybe we go 1 up, 1 down. We do a hemicorpectomy from one side. We leave the midline structures completely intact. I think it's important to understand that you can perform separation surgery without instrumentation. You don't need to use titanium or carbon fiber screws in all of these cases. This is a 40-year-old patient I took care of about a year ago. She has circumferential epidural disease from breast cancer, right? We have tools with 90-degree angles that can reach in front of the ventral epidural space, right? So we don't have to do these very big operations anymore. Over-the-top decompressions. I do this a lot from my degenerative population. We could place a tube. We can do midline sparing techniques such as this. This is a patient, again, with breast cancer. She presented to us to our ED with a foot drop. She has severe epidural disease on the right side. We can see her facet. Her pedicles are completely eroded. Rather than taking her for a big instrumented operation, we take her for an incision that's about this big. We leave the midline structures completely intact. We take the pedicle down. We now take out that epidural part of the disease, and we close her up in about 60 to 90 minutes. It's a very quick operation. So the paradigm has definitely shifted more towards taking care of these patients with metastatic disease a lot less invasively. There are situations where maybe we want to be very aggressive, Pancoast tumors, performing sagittal osteotomies. When I got to UNC, I noticed that our surgical oncologists are fairly aggressive with locally advanced rectal cancers. So I found myself doing a fair amount of sacrectomies on occasion in these patients that have contiguous disease from the rectum to the sacrum. And these are situations where we can actually modify the degree of metastatic potential of some of these cancers. So what it really boils down to is we have to take a multidisciplinary approach to these cases. You do have to take into consideration body composition, molecular markers, integrate AI into your practice when available, and then pick a prognostic tool that works for you. The New England Spine Metastatic Scale Score works for me. I use it very frequently. And then obviously, as we gain more experience, I think this is ultimately what gives us the best ability to predict survivorship with this disease population. So thank you, and open to any questions.
We'll have to get to our break, but Dr. Galgano, yet again, a great and thought-provoking lecture. I like to give that, I show that question mark sign of the spine also quite a lot. Let me ask you a question in your dual function of Chief Quality Officer in your institution and spine surgeon / oncologist. In the quality world, we use O to E ratios a lot, observed to expected. And this is one of those nice little numeric kind of gamesmanships, because if you put something into the expected category, you can lower your complication rate pretty dramatically. So how do you put, or how do you rate spine oncology patients objectively to do due diligence to the severity of their illness? And how does that reflect in the objective complication reporting?
That's a fully packed question. So I'm not sure if I'll answer this the way you're looking me to, but something that we do at UNC, and I'm sure many other institutions, we have multidisciplinary tumor board. We have neurosurgical conference didactics every Wednesday, and we prospectively go over cases. So I think it's really important to go over these cases before you actually do them and go over the complexity of these, right? Whether it's a deformity or a spine tumor case. And I talk to my colleagues, I talk to the residents, rotating medical students, and obviously patients and families about what to expect afterwards and the high degree of complications with these. So I think it's really important to be very upfront, not just with your patient and family, but also with your colleagues as well. And you could say, you know what, this is a patient that they're getting, radiation after surgery. There's a fairly high rate that you may see this patient back on the M&M list in 6 or 8 weeks, and almost kind of like prepping everyone just so that they have an understanding that this is a very at-risk population of patients.
Dr. Bilski, your microphone.
Yeah, Mike, that was stunning. Thank you. It was brilliant. I think New England Metastatic Spine Score and SORG are amazing predictive models of survival, and I think sarcopenia is going to be really important. I think the one thing that we haven't really addressed are medical issues that are inherent in that population. They're older and they have heart disease or lung disease, and I think the next iteration, maybe for you to look at, would be maybe how those medical complications play into taking somebody to surgery. And I just took a non-small cell lung cancer to surgery for a really simple surgery, and he had myasthenia, and we probably didn't address that adequately, and unfortunately ended up reintubated, 3 hours after surgery, and the patient's family, for whatever reason, made him DNR. But the medical issues in this population are so overwhelming. We actually don't have that integrated into these either survival models or, whether we should take those patients to surgery. And I wonder what you're using and how you feel about that.
Yeah, absolutely. I don't really have a true algorithmic approach to it, but I've run into similar situations where patients have had pre-existing cardiac disease and have an MI 3 or 4 weeks. I've actually had two patients when I used to work up in SUNY Upstate in Syracuse that had MIs after about 3 or 4 weeks after spine tumor surgery. It's definitely something that I'd like to look further into. I mean, we do get medical clearance on all of our patients, whether it's oncology, deformity, anyone that's admitted to the hospital. But by and large, I mean, everyone gets cleared for surgery, right? It's pretty rare that the medicine doctor says a patient's not cleared for surgery when they have severe spinal cord compression. So I really think that we do need to look into that as a specialty, but I also think it's worth prepping these patients. There's plenty of patients that have a laundry list of medical comorbidities, like that case I showed you, that now, based on my experience, I say, you know what? I'm not taking you to surgery. There's less invasive options, maybe. You may not get the same oncologic outcome that we all wish that you have. But at the end of the day, we don't want to kill you with our intervention, right? Or the post-operative course. So it's definitely something that you're right. It's not integrated into any of the current scales that we use. And I think it's absolutely something that we need to start looking further into.
Thanks. Great talk, Mike. Thanks so much.
Thank you.
Yeah, echo Dr. Bilski's statement. One more question. I asked that to Dr. Meyer before from Munich. Optimizing patients, picking up what I just said. So A1C scores, nutrition, do we use that? How long do we give a patient prior to improving? And again, the patient has pain. Sometimes they have neurology. How realistic is it to try to optimize patients who are impaired?
Most patients I do spine tumor surgeries on come in through the ED, unless it's a primary tumor and they're just kind of, have some back pain. Maybe they have a chordoma, what have you. Most patients from metastatic disease I operate on, they find their way through the ED. So there's usually not a whole lot of time to optimize their albumin levels, their A1C. I wish there was a better way. This is really where multidisciplinary tumor board comes into play, is trying to identify these at-risk patients before they get to that point, maybe intervening beforehand. But outside of that, I don't think there's a fantastic way, of intervening for their A1C of 10.5 prior to an intervention.